would like to define chronic pelvic pain for me?
The pelvic pain lasting for more than 6 months.
Great, very good. And anything else? Okay, what do you think? What are the common conditions associated with chronic pelvic pain?
Madam, endometriosis.
Okay, and?
PID.
Right, very good. What else?
And it can be idiopathic as well.
Yes, idiopathic, okay. There are so many things, come on.
Adenomyosis.
Very good.
Bladder pain syndrome, muscular pain, neurological pain.
Very good, excellent, yeah.
Psychological, neurological.
Very good, great. Okay, so we have already an idea that it can be multifactorial, this chronic pelvic pain. So if we go by the definition, as you can see, that it is some who said that this is a pain which can be defined as intermittent or constant pain in the lower abdomen or pelvis for at least 6 months in duration, and it is not occurring only with the menstruation or with intercourse, and it is not normally associated with pregnancy, or it can be associated with pregnancy. It is very common, and it affects perhaps 1 in 6 of adult female population. So that is something very common we see every day, right? So what are the different causes? So try to, whenever the station of any lower abdominal pain comes, try to, broaden your thinking and think in terms of gynecological causes, urological causes, abdominal causes, and malignant causes. So we can just think about like gynecological causes, as somebody rightly said, endometriosis, adenomyosis, fibroid uterus, ovarian cyst, hydrosalpinx, ovarian remnant syndrome, PIDs, adhesions, and post-tubal insert drain syndrome. Then in terms of urology, you can think of interstitial cystitis, bladder syndrome, radiation cystitis, cancers, urethral syndrome, recurrent cystitis, recurrent chronic urolithiasis. Then there are certain gastroenterological causes, especially irritable bowel syndrome and inflammatory bowel disease. So we will be doing 2 stations today, and anybody of you can come forward and try to do the station. Don't feel shy, it is just a matter of practice, and you will definitely learn with your performance here. So because this is a recurrent, every time it's coming, most of the time this is station, a young female who comes with abdominal pain and the symptoms. Anyways, we'll do the station and then we'll talk about it. So as we were talking about the causes, you can have musculoskeletal causes, then we can have neurological causes. So whenever a woman who comes with pelvic pain and you cannot find anything, please try to go and find out if she is having some depression, some anxiety, some other problem is there. Then what is the initial history would you like to know in a patient who comes with the pain in lower abdomen? Anybody, please?
Yes, ma'am. Pain. What is the character of pain? What is the aggravating factor? What are the relieving factor? Any associated urinary or bowel problems? And association with the menses.
Great, very good.
Any discharge down below.
Okay. And what else? Someone else would like to add?
Fever, cough.
Great.
And also, how is it affecting the quality of life?
Yeah, this is very, very important. I think I can hear myself back. Now it's okay. Yeah. So quality of life is very important, especially once you come to MRCOG, this word quality of life, they want to hear from your mouth that how is it affecting her quality of life. So please do ask this question that I can see that you are suffering from this pain. It must be affecting your quality of life. Can you tell me more about it? Okay. All right. So initial history of the patient, you should try to inquire because we have some differential diagnosis in our mind. So we want to, go to the diagnosis by asking few questions. So if we are concerned about endometriosis, so definitely we'll check if the pain is with the menstruation or it is not. Or then pelvic inflammatory disease, you will ask about any discharges, any sexually transmitted infections. Then if you are thinking of irritable bowel syndrome, then do ask about her bowel habits. If you are thinking about some urinary tract infections, so talk about the waterworks problem. Some musculoskeletal, if the pain is associated with some particular movement, sitting, prolonged standing, or lifting something, or if you feel this is, you don't find any of these causes and you feel the thing is something psychiatric, then you have to talk about anxiety, depression, any recent event which happened in the family, which has changed her things. So this is very, very important. Then as somebody said that what would you like to know if what are the more things associated with the pain? So of course you have to ask how much is the pain? Is it constant or coming and going? What are the aggravating and relieving factors? Is it radiating somewhere? Are there any other associated features? Like if you are thinking of bowel problem, then you will say that do you have any vomiting, diarrhea with the pain? If you feel that there is PID, then you will ask that is the pain associated? Is it increased during sexual intercourse? Things like that you have to keep in your mind once you are taking history from the patient, because history is very, very important. It is the history which will lead you to the diagnosis. The examination and the investigation, they come later. They will only support your diagnosis, but it is mainly the history which will tell you the diagnosis of the patient. Okay, this is also something very important to ask in the Western world. I think it is common in our part of the world as well, but we don't talk about it. But there you have to check. So you can ask a leading question that are you on some drugs or any recreational drugs you are taking? Then check about yes, domestic violence. Domestic violence also can come as a chronic pelvic pain. This is very, very important. So please try to ask how is her support at home? Is her partner supportive? Especially once you are doubtful about your diagnosis and the history is not leading you to any other conclusion, then you should be concentrating on this part, that is her partner supportive? Is everything okay at home? So these are something very, very important you need to ask in the history. Okay, so any questions so far? Okay, so no question. After completing your history, you go for the examination. In MRCOG, you are not supposed to take the examination, but for MRCPI, they expect you to perform examination. Before COVID era, the examination was on real patients, but now the examination is on mannequin. Anyway, since we are not just exam focused, we are talking in general as well. So once a patient comes to us with such history, what all we need to see while we are examining the patient is like some general findings and some local findings. So generally, of course, you need to know the vital signs of the patient. What is the general appearance of the patient? What is her mood and emotional state? How is she walking to the couch? Once she's sitting, how is she sitting? Is she sitting straight, or is she bending herself? So maybe that pain is related to her spinal column. Then abdomen, you need to see the appearance for the fat distribution, any scars are present. If scars, of course, you will think about adhesions that is as a cause of pain. Then you will look for the masses, hernial orifices, inguinal adenopathy, pubic symphysis pain. You will do light palpation, and then you can do some deep palpation with the single finger. You will look at the extremities of the patient, and you will look for muscle strength, tone, and any asymmetry. Then comes your pelvic examination. Of course, you will look at the external genitalia for any lesions, abrasions, ulcerations. Then you will perform a single-digit vaginal examination, and then you will perform a bimanual vaginal examination. It is always a good idea to perform a rectovaginal examination to look for any nodularity or tenderness in rectovaginal septum for endometriosis. And speculum examination is, of course, very important, where you will have a naked eye examination of the cervix. And if needed, you can perform a pap smear, swab, and you can have a look at the discharge and the condition of the cervix. Okay. Allodynia. Who's this? Did I talk about allodynia? Actually, allodynia, I don't know when I talked about allodynia, but the thing is, it is something, if a stimulus causes pain, and which a normal person will not feel that pain, and only some particular people will have that pain, where certain stimulus will cause pain. So, you know, it is something which will go with the psychiatric problem, not otherwise. Am I clear, doctor?
Yes, ma'am.
Okay. All right. Okay, maybe I didn't see. Sorry. All right. So where were we? Okay. So as we discussed, there's so many causes are there for the chronic pelvic pain. Then from the very first appointment, we have to try explore the patient's symptoms, and develop a rapport between the patient and you, so that she tells you exactly what is happening with her. So I think we'll go with first one station, and then we will discuss this in detail. Who would like to take the station with us? Anybody?
Can I take Dr. Uzma?
Sorry?
Hello?
Hello, yeah?
Yes, I am Bismil Said. Can I take this station, please?
Yeah, sure, Bismil. Sure. Okay, so I'll show you the station. Okay, this is your station. So you will have 12 minutes for it. 2 minutes is your reading time, and 10 minutes is your performance time. Okay?
Yes, okay.
All right, so I'm putting the timer for you right now.
Okay, next, please. Any other slide?
This is all you have. No other
Okay.
slide. You want to arrange yourself? You have 2 minutes.
तानिया ये इतराज में ना मेरे 50s पड़े हैं मुझे तो ऊपर वाले में लेफ्ट पे सबसे टॉप पे
Please, other people, try to mute yourself.
जी बेटा
Okay, doctor, shall we start? Dr. Bisman? Am I audible or no?
Yes,
Hello?
Yeah. Shall we start,
Yes.
doctor?
Yes, okay, I am starting. Actually, I was muted. Hello, I'm Dr. Bismil Said, one of a doctor in the gynae clinic today. May I please check your name and date of birth?
Hello, doctor. I'm Deborah Stone and I'm 22 years old.
Okay, and how may I address you?
Deborah is fine, doctor.
Okay, so Deborah, I understand from your notes that you are being bothered by the lower abdominal pain, and today you are here to discuss your management options. Am I right?
Yes, doctor. You know, I was following with my GP and he seemed to not understand my problem. That is why he sent me to you. And I don't know why this pain is there. It's really bothering me a lot.
I'm so sorry to hear that, Deborah, but I assure you that I will try my best to help you today. But before starting this consultation, I may need to ask some personal questions, and whatever you will tell me, that will remain confidential. Is it okay?
Yes, doctor. Thank you.
Okay. So, Deborah, could you please tell me a little bit more in detail about this pain?
Yes, doctor. See, this pain started maybe almost a year now. And initially I was ignoring the pain, but then it started to bother me a lot. And, you know, I discussed with my friends and my neighbors, and I don't know, they told me maybe I have endometriosis because, you know, my friend, she had same type of pain, and then she checked with the doctor and he told her that you have endometriosis, and she got this keyhole surgery done. So maybe I also have endometriosis. So I thought, I went to my GP, but he was not, you know, happy with my idea of the diagnosis I made for myself. But he sent me to you. But this pain is coming, going. I don't know what is this pain really.
Okay, so Deborah, is this pain is associated with anything which increase or decrease this pain?
Not really, doctor. Sometimes I feel certain type of food if I eat, then I will have more pain. Sometimes it increases with my pain. Sometimes no. Sometimes once I want to go and pass urine, I feel more pain. But it is not, you know, it's not constant like this.
All right. And is this pain is associated with any diarrhea or any constipation alternatively?
Um, yes, doctor. I feel like this that sometimes it is constipation, sometimes it is diarrhea. I feel that this is also happening with me.
Okay. And is this pain has any specific relation with the dairy foods like dairy products, milk and eggs like?
Um, no, I really don't eat too much of dairy products, but I've really not, you know, tried to make an association between my food intake and pain.
And Deborah, what about your periods? Are your cycles are regular?
Yes, doctor, my periods are, I have a 28-day cycle and they are very regular. 5 days I bleed. Yeah.
And when was your last menstrual period date?
It was 10 days ago.
Any problem with your water works?
What do you mean? What type of problem, doctor?
Okay. And is this pain is really affecting your quality of life?
Yes, really, doctor. You know, I am a student, and because of this pain, I have to miss classes, you know, take painkillers and go and relax. You know, my teachers are not happy with my frequent absent. So really, it's affecting me. I don't enjoy my friends' company because I don't know when this pain will come and my mood will be off. So yeah, it's really affecting me.
I'm really sorry, Deborah, that you went through a lot. We will be going to arrange some of a support group and counselors for you so that they will really offer help. Would that be okay?
Yes, no problem.
Okay. May I ask you some questions regarding your sexual life? Are you sexually active at the moment?
No.
Okay. And any medical condition for which you follow your GP?
No, doctor.
Any history of surgeries on your tummy and down below?
No.
Okay. Are you allergic to any medication or any food?
No, doctor.
Any family history of concern like endometriosis in the family, as you told your friend has, anyone in the family has the similar?
Not my family, but so many people in my social circle, they have endometriosis. So I think I also have endometriosis. I think, you should do surgery for me to check if I have endometriosis.
Yeah, sure. We are coming into in a bit while. So may I know what is your BMI?
My BMI is 25, doctor.
Okay, and what's your blood group?
I haven't checked.
Okay, and may I ask you some questions regarding your social habits, if you don't mind?
Yeah, sure.
Do you smoke?
No, sometimes with friends.
Okay, and drink alcohol or any recreational drugs?
No, that recreational drugs, no. But yeah, occasionally I do drink with my friends and parties.
Okay, that's fine. Okay, so Deborah, coming on to whatever you have told me, is there anything that you want to add in your history?
No, doctor, only as I told you that I feel I have this endometriosis. So I just want to be, have a keyhole surgery done to check because I am just fed up with this pain.
I really understand. If I would be in your situation, I will react in a similar way. So, Deborah, I need to examine you in the presence of a chaperone. I just asked my nurse to check your blood pressure and your pulse, and I would examine your tummy to check for any mass or any pain. Would that be okay?
Yeah, that's fine, doctor.
So basically, Deborah, what I feel from your history and examination, I may need to offer you some more tests like ultrasound of your lower tummy and also some blood tests. But what I feel is that you are having the condition that is called inflammatory bowel, irritable bowel syndrome. Have you ever heard of that before?
No, what is that? I feel I have endometriosis, no bowel disease, doctor.
Okay, actually, the history you given, that is your pain is associated with your bowel problems, and also it is means I don't find anything that that is associated with endometriosis. But anyhow, what if we try some diet modification and we will see that is it really working for you, and then if it is not, then we will work on the endometriosis. So what are your thoughts?
All right, that's okay. If you feel it is going to help me, I'm ready to try.
Thank you so much, Deborah. So what we will suggest is that I will offer you a pain diary, maintain a pain diary for at least for the period of 2 to 3 months, and check on the food that you are taking and cut out the foods that are spicy and see how they are working. Is they are relieving your pain or aggravating your pain? Am I clear?
Yeah, okay.
And I will yes, try to avoid spicy food and carbonated drinks, and take a plenty of water, take a fiber diet, and try to avoid taking caffeine in the food because they will cause irritation of the bowel, and that's why you are feeling pain because of the spicy food and these products. Am I clear, Deborah?
Yeah, doctor, but you told me 2 to 3 months I will, but what about my pain in for 2 to 3 months?
So, yes, you are very right. In that case, we will be putting you within the team of our doctors that would including our special pain management clinic. They will offer you a very good painkillers you can take in the form of NSAIDs, paracetamol, as well as I will offer you an appointment with the psychologist and counselors so that they will deal with your, they will talk to you and they will really offer help in relieving your pain. You can also take antispasmodic treatment for the period of 3 months. So these medications will help to calm down your bowels and they will help to relieve your pain and pain that you are having at the moment. So what do you say?
Okay, if you have some treatment for me, then it's okay. I will take that.
Yes, actually, we usually offer the diet modification, maintain the pain diary, take a good painkillers, antispasmodic, paracetamol, have appointment with our multidisciplinary team. They deal with all situations, and then we will give an appointment after the period of 3 months So, or maybe for a few weeks on the telephonic appointment to check that how you are going with all these modifications. Okay.
All right. Okay, doctor.
Apart from this, I will also suggest you to try to avoid taking dairy foods, because sometimes there may be a cause, and try to take a fiber diet and try to avoid the spicy food. And apart from this, I will also arrange an appointment for you with my consultant so that you can also do your
Time
concerns with her.
finished, Dr. Bismil. Your time
Okay.
finished.
I was just giving you
All
the
right. It's all right. Very, very well done, Dr. Bismil. Excellent. I'm very happy the way you took the station. Great. You answered almost everything and you covered almost everything and you passed the station. Dr. Zaib is here with us. Yeah. Dr. Zaib, if you can give some, please, feedback to our participant. I think Zaib, can you hear us? I think she's not there. Anyways, okay. Bismil, what do you think, how you performed the station?
Actually, doctor, I would like to, differ you from the laparoscopy endometriosis. That's why I just tried.
No, this is a real, exam station. It came in my time, and it was a young girl, and she was continuously, I really allowed you to talk. She was not allowing me to talk at all. And such stations will come, somebody else also from the community will be sitting there. So there will be a consultant. Most likely such stations are with the observer from the community, because if you are passing Mrcog, they should see that you are a safe doctor to practice in UK. So they observe you how you talk with patients. If patient is coming with her own agenda, like this girl was continuously saying, no, don't ask me all these questions. I know I have endometriosis. I want treatment for it. Do my surgery. So how to deal with such patient? You cannot say, no, you don't have endometriosis, but you say, yeah, you can have endometriosis, which you rightly said, did very nicely. You covered the station and, you told her, guided her nicely. So this is how in such patients, your marks are not only for your applied knowledge, but there are many more marks with the communication with the patient. And here what you missed, because in RCOG, there are 5 domains which they are testing you about. This is like communication with the patient, communication with the colleague, patient safety, applied knowledge. So here you just missed this communication with the colleague part, where if you're suspecting irritable bowel syndrome or inflammatory bowel disease, you have to send her to the gastroenterologist, right?
Okay.
So this part you missed. Rest, you covered everything well. Your applied knowledge was good. Although you took the history for quite long, almost more than 5 minutes. So that's why the time for the discussion was not that much for you. And yes, since I told you that I'm not sexually active, so you just didn't ask anything about the STIs and all. But that patient was sexually active, so you should keep some time for the STI screening as well. Okay?
Okay, doctor.
Anyone
Thank you, doctor.
else? You're welcome. Anyone else want to comment on this station?
Can I say? I'm Sadia. Can I say?
Yeah, sure.
Yeah, she did very well. But I am concerned, like when patient is asking her something, her concern should be addressed at the same time. Like when she asked about any urinary complaint, a patient said, what do you mean urinary complaint? So I think it was important at the same time that to ask the patient any cyclical urinary complaint or not. And when she said that I have endometriosis or not, so it's okay. She said could be endometriosis, but I think at the same time should ask dysmenorrhea, dyspareunia, so that it's ruled out at the same time. otherwise we will forget. And when patient asks that I am not sexually active, right now she is not sexually active. Before she might be sexually active. This might be PID. So previous history of sexually shared infection, it's important to ask.
Yeah, you are right, Dr. Sadhya, but she did ask about the dysmenorrhea, menstrual history she asked, and you can rephrase your question. If the patient says I'm not sexually active, then you can just say, have you never been sexually active? So that will, you know, give a clear clue that if she started her sexual activity or no. Then for the waterworks problem, like urinary problem, if the patient says, what do you mean? Then you can say, yes, you can add 2-3 lines that, okay, do you have any burning while passing urine, pain while passing urine? But since the role player was saying that, no, I don't know, sometimes it is with the urine, sometimes it is with the bowel, I don't know, it is not associated really with anything. So that's why you have to cover so many things in this station. So if you have just touched even waterworks, that is okay, enough. That means the differential that is there in your mind for a pain in the pelvis, you have touched that. So you got your marks for that. But if the patient has some really UTI, then she will give you a clue there in the history that, okay, my pain is more with the micturition, or I feel burning micturition, I feel going all the time to the toilet. So it will be there. Okay.
Yeah. And I think when starting management, from the start, we should say we will involve the team of the doctors, which will include gastroenterologist.
Yeah, that is very important, that it will be a multidisciplinary team who will manage your case. There will be a gastroenterologist, there will be a pain doctor. That is very important, okay?
Counsellor as well.
Sorry?
And, yeah, and after a team of the doctors, we can make it more organized. Like there could be general measures, food, whatever doctor is telling, this food, then medical treatment. And I think, I'm not sure, but I think we should also tell a little bit about laparoscopy as well. Sometimes we are not, even we are doing laparoscopy, but we are not sure about the cause of the pain by laparoscopy as well. Sometimes negative laparoscopy.
Yeah,
Because
that is all.
Again and again about laparoscopy.
Yeah, she was asking about laparoscopy, but the thing is, if you start talking only about laparoscopy, then your time is gone and you will not address her main concern. You have to, that's why I'm saying that you have to complete your history within 3 to maximum 4 minutes. The history should be there. And then you will say, okay, laparoscopy, sometimes we, even after performing laparoscopy, we don't find any reason of your pain. So before we go for laparoscopy, there are a few things I would suggest that you start doing. And if still we don't reach to a conclusion or diagnosis, then we might go for laparoscopy to find the cause of your pain. Is that okay for you? So these are the few things you have to manipulate by talking to the patient. So it will cover everything. I think it's all clear now, right?
Yes, yes. Thank you.
Zaib, are you back? I think there is some power problem happening in Karachi, especially. So there's a problem. Anyways, okay. So once we are having a patient with this pelvic pain, as we already discussed, that she might have endometriosis. So endometriosis, there are a few clues, like nature of the pain. There will be variation with the menstrual cycle, and then dyspareunia, dysmenorrhea, painful defecation, and there will be family history. There can be family history. Then examination finding, you can find local tenderness, thickening of uterosacral ligaments, nodularity. Then if your diagnosis is adenomyosis, then of course there will be marked variation with the menstrual cycle. There will be irregularity and menorrhagia, and the uterus will be big, globular uterus, tender. Pelvic inflammatory disease, the variation of pain is mild. It is not associated with the period mostly. It is all the time there. There will be associated vaginal discharge, irregular bleeding, and any recent change of partner stream might be there. On examination, you will find cervical motion tenderness, and some cervix may be unhealthy to appear, and there may be contact bleeding. If the patient is having pain due to adhesions, then there will be history of previous surgeries or infections. Then irritable bowel syndrome, the pain will be related to the bowels. There can be history of constipation, diarrhea, mucus, bloating, all these things. If urological pain is there, then it will be associated with your urine, nocturia, frequency, hematuria. Musculoskeletal will be with the movement and posture of the patient. Then a nerve entrapment can be there sometimes. The patient will give typical history of shooting or burning pain in some particular area. So mostly that pain is with the nerve entrapment. But normally people, the examiners will not put patient, cases like with nerve entrapment, but this should be in your mind while you are doing the station of chronic pelvic pain. And then psychological component, which is very important. And in this, mostly you will not be able to, grasp anything from the history, but you might, if you ask about psychiatric, like history of depression, then you will reach to a diagnosis. Because there is one station where the female is coming again and again, and many people, they forget to ask about any history of depression and anxiety. And finally, those people who asked, they told her that my sister passed away recently, and my mother also passed away, so I feel lonely. And since then, she was having pain. So the pain was not related to any of the gynae problems. It was psychological component of the pain. So which most of the people, they missed. So once you are taking your history, please try to follow your template, and then only you will reach to a diagnosis if you tick everything in the history template. Any questions so far? Okay, so this is all from your guideline, for the diagnosis of irritable bowel syndrome. What all you need to ask from the patient, if the pain is increasing with the defecation, if there is any association with the frequency of stool, the form of the stool, and there are any symptoms of bloating or mucus is there in the stools, and any extra intestinal symptoms like lethargy, back pain, frequency dyspareunia may also occur with irritable bowel syndrome. So, it is not just the bowel symptoms, you can have other symptoms as well, but still your diagnosis can be IBS. So this is just briefly about IBS. You have to avoid triggers. Some dietary advice you will give to the patient, as Dr. Bismil gave very rightly. Any triggering factors, if the patient can identify that, okay, with this type of food, I start to have more pain. So you will tell her to avoid that food. And a healthy lifestyle, of course, always it helps in whatever diagnosis. Antispasmodics will be given, and patient may need laxatives or antidiarrheals as per her need. If she's having diarrhea, of course, you will give her antidiarrheal. If she's having constipation, you will give her laxative. And sometimes tricyclic antidepressants also can help such patients. Probiotics are still under study, but they may also help. Then behavioral therapies, and this pregabalin, it can also be used for such patients. Okay, and yes, you have to ask about these signs, especially if the patient is old, because this might be the only symptom for underlying cancer. So you have to ask about bleeding per rectum, any pain, bleeding after menopause, pelvic mass, suicidal ideation, excessive weight loss is there, irregular bleeding after the age of 40, or postcoital bleeding. How you will investigate? If the patient, suppose this one was not sexually active, but a patient who is sexually active in any age, then you have to start by screening for infections. Then the ultrasound, if the patient is virgin, you can go for an abdominal pelvic scan, otherwise a transvaginal scan will be the best, and then laparoscopy. If the patient is old and there are symptoms of bloating, weight loss, then of course you have to go for CA 125 as well. Then what are the options available for anybody with chronic pelvic pain? Like this patient, you can also give her this trial of hormonal treatment for a period of 3 to 6 months before you, go for a laparoscopy. So this can also be, Dr. Bismil just went to this one, irritable bowel syndrome, but if you can also, talk about that, okay, maybe you are right and your diagnosis is endometriosis, but before we go for this laparoscopy, why not we try this hormonal treatment for a period of 3 months? And if your symptoms improve, then we'll continue the treatment. You can talk like this to the patient. So antispasmodics you can give if you have irritable bowel syndrome, and if the patient is still complaining of pain, then you can refer her to the pain specialist clinic. Okay, so any questions about this station? Okay, Zaib is here. So Zaib, since you have finished making your tea, can you enlighten us, please?
Yes. I 100% agree with, whatever you have talked about this. I just want to supplement, in terms of that, we have to focus on psychological assessment. We have to focus on alternative diagnosis as well. There are 2 and 3 most important MRCOG, the recall questions as well in part 3, in which the question is coming as that she wants to go for laparoscopy because she thinks that she is having endometriosis. And in turn, that question turned out to be the IBS. So yes, we have to exclude almost all causes of the chronic pelvic pain. And yes, Bismil has presented very well, but I would like to advise Bismil that please do use more patient-friendly language, okay? Like you said, what I have, because I've been busy in kitchen, but whatever I was listening to, so you said that we will do the anti-spasmodic, we will give you the the inflammatory, maybe I'm wrong, but these 2 things I have overheard. So, you have to explain it in the layman language, okay? That we are going to give you some, the pain relief medications, and they are going to relieve the spasm of the, the gut, and this is going to give you some kind of relief afterwards, okay? So in terms of whenever you take history, always take history and then tell her that why do you want to ask that question, okay? Because chronic pelvic pain, of course, you have to have at least 4 to 5, the things initially on top of your, the list that, these questions are must to be asked, okay? And after that, of course, when you are going to define it, so always try to engage the patient. Always try to engage the patient, because that is going to give you a good idea that, okay, patient is with you. And whenever you are going to explain something, then, give the information in chunks, involve, and then ask, am I clear so far? Am I clear so far? Am I clear till now? Do you need anything? Do you want me to repeat anything for you? Okay, do you have any question? So this looks, very engaging. Otherwise, I think Bismil has presented very well, and and rest, I agree with you. And of course, this is a very important exam scenario, and RCOG never forgets to bring this question by, the all angles, be it the sexual assault, be it like vaginismus, be it like, anything. So there can be multiple elements for this particular scenario. So thank you so much, Dr. Uzma. Thank you, Bismil. It was a good attempt. Anyway.
Thank you so much, Zaib.
Thank you so
Okay.
much, Dr. Singh.
Thank you.
Who is there saying thank you to us?
He's my little son.
Oh, okay.
Cute, how
Thank you for being there with Mama.
So
Great
cute.
support, huh? Okay. So, who would like to take the next station?
Shall I, ma'am?
Dr. Monicum?
Yes, ma'am.
Okay, well, who else? Because Dr. Monicum, we are giving every day feedback in our group. So anybody else would like to participate? Dr. Abia, who is this? Sorry, I cannot.
Yeah, Sadia.
Yeah, sure. Yes, Sadia, you can, no problem. Is it okay, Dr. Monicum?
No problem, ma'am.
Okay. All right, Sadia.
Yes, please.
This is your case. You have 2 minutes reading time, and your time starts now. Hello, can we start?
Yes, please. Hello, I'm Dr. Sadia, one of the doctor in the clinic today. May I confirm your name and age, please?
Hello, doctor. I'm Kitty Simons and I'm 35 years old.
Kitty, I apologize you that my consultant isn't available. Is it okay if I see you on behalf of my consultant?
Oh, with great difficulty, I got this appointment and now your consultant is busy. What is this?
I'm really sorry for this, and we are looking into a matter to avoid such happenings in the future. And if you say I can book a next appointment with my consultant.
Okay, if you can help me, that's fine.
Yeah, sure, Kitty. I understand from your notes that you have pain in your lower tummy. Is that right?
Yes, doctor, I have this weird pain in my lower abdomen and it's really affecting me a lot.
I'm sorry to hear about it. We are right here to help you in this situation. May I know your specific concern you want to discuss with us today?
Yeah, my concern is this pain. I want to know why I'm having this pain and I want to be treated for this pain because it's really affecting my life so much. I'm unable to, do the daily work and even my husband is not happy. So really it's affecting me too much.
I'm sorry to hear about it. And I would like to ask you a couple of questions and then I would address all your concern and come to mutually agreed acceptable management plan. Is it okay, Kitty?
Yes, doctor, it's fine.
Okay. So Kitty, please feel free to stop me at any point if you have any question or you want me to clarify something.
Okay, doctor.
So Kitty, can you tell me a bit detail about your pain?
Yeah, doctor, this pain is there for quite some time, maybe 6, 7, 8 months like that. And I feel this pain is,
Hello?
Yeah, can you hear me?
Hello?
Hello?
Yes, yes, please.
Yeah. This pain is coming, doctor, more once, I feel I want to go past urine. Once I pass urine, the pain is less. But then again, gradually the pain will start increasing. So it's all the day there. I get up so many times in the night to pass urine and I feel so much discomfort in the night. My night sleep is so disturbed. I have to go frequently to pass urine. So because I feel that once I pass urine, I feel relieved. Yeah, doctor, this is really bothering me a lot.
I'm sorry to hear about it. So Kitty, can you tell me that how many times in a day and night you need to visit to the toilet?
Maybe 8 times in the day and 3 times in the night.
Any history of urinary leakage during sneezing or coughing?
No, doctor.
Do you need to rush to the toilet?
No.
May I know about your dietary intake, dietary habits?
Yeah, I like to eat spicy food, Mexican spice. I love it. So we eat spicy food. Yeah, that's it.
Do you think yourself that your pain increases when you take the spicy food?
It's all the time there for past 6, 7 months. So, I cannot really make an association with my food intake and with the pain.
And do you think, do you have need to rush to the toilet while passing the urine?
No, doctor.
Okay, any burning sensation or stinging sensation in the water box?
No.
And do you have any time to notice that there is blood in your urine?
No, doctor.
Okay. And have you taken any treatment for this problem? Any workup done?
No, I just did only routine painkillers, over-the-counter drugs. Then I booked appointment because I felt there is something really wrong. That's why I came here. Nothing as such done before, only normal painkillers I used to take.
Okay, I have a personal question. Are you sexually active?
Yes, I'm married.
Okay, and are you having any contraception?
Sorry, doctor, what?
Are you practicing any contraception right now?
Yes, I am on oral contraceptive pills.
And how about wishes to have further babies?
Yes, doctor, I have 2 children and my partner is really very keen to have a 3rd child. But because of this pain and discomfort, I'm not able to have any sexual life. So, you know, he's also angry.
I'm sorry to hear about it, and we will support you in this situation. We will try our best to help you. And do you have any vaginal discharge or fever?
No, doctor.
Any bowel problems?
No.
Do you have any medical problem?
Medical problem means what, doctor?
Yeah, do you have any raised blood sugar levels?
No.
Okay. And I understand from your notes, and you told me that you have 2 babies. May I know about your deliveries?
Yes, they were normal deliveries. Everything was fine during the pregnancy and after the delivery. And my last child is like now 8 years old. Yeah.
Okay. All right. How about your smear test?
Yeah, I did one. It was 1 year ago and it was normal.
Okay. Any surgeries from tummy or down below?
No, doctor.
Any family history of concern?
No.
Any drug allergies?
No, doctor.
Do you smoke?
Yeah.
May I know more about it?
Yeah, I'm smoking for like maybe 2 years now. And sometimes 10 cigarettes, sometimes 15 cigarettes. Yeah, and it depends on my mood and my stress.
I don't mean to be paternalistic or judgmental, but it's very relevant to your symptoms and to for your general health. Have you ever given a thought to quit smoking?
No, it helps me to get away with the stress I'm having with this pain and my work. So, you know, not really.
Okay, if you think like you want to quit, we have a lot of support available. I can connect you to the relevant services.
Okay, doctor, thank you.
And are you aware of your BMI?
Yeah, it's 27.
Okay, any alcohol intake?
Socially only.
Okay. Any recreational drugs?
No, never.
And how is support at home?
Yeah, I live with my partner. He is very supportive. But the thing is, because of this condition, we are not really on talking terms now.
What do you do for a living?
I'm running a business and I'm very busy at work. That is why I take the cigarette, and you know, this pain is really bothering me a lot.
Thank you very much for sharing all this information with me. Would you like to add in something?
No, doctor. I think you asked everything.
I would like to examine you in the presence of the chaperone if it's okay with you.
Yes, that's fine, doctor.
Hello?
Yes, doctor.
I would like to examine you in the presence of the chaperone if it's okay with you.
Yeah,
Hello?
it's fine, doctor.
Yeah.
Dr. Sadia, can you hear me?
Yeah. So
yeah, okay.
Coming towards I have gathered from your history and what I have got that you have got a condition which we call it as a bladder pain syndrome. Have you heard of it before?
No. Is it something dangerous?
It's not exactly something dangerous, but if it's go untreated, then it can affect, as it's already affecting your quality of life. Then it can get worsen and it can worsen your quality of life further. But it's not something which is not treatable or something which is life threatening. Am I clear so far?
Yes, doctor. So how are you going to treat me?
Yeah, we have got a good management plan for this condition. We will involve the team of the doctors. It will be my consultant, the specialist nurse, the urogyne doctor as well. And we will also connect you to a counselor. And I would also, then we will start with simple measures that may include the food diary. And we will also check you for waterworks infection as well. And then we can start for you the medication as well. We can provide you with the painkiller, but before this, we will ensure that you are not allergic to any of these medication and you don't have any contraindication. And we can also...
Your time finished, doctor. But anyways, there was a lot
Hello?
of disturbance. Yeah, you can continue, although your time finished.
Hello?
Dr. Sadia, can you hear me?
Hello, I can't hear.
We can hear you very well, Dr.
Hello?
Sadia. Okay. Hello. Anybody else has this problem? My voice is clear to others?
Yes, ma'am, it's clear.
Okay. Sadia, can you hear me now? I think there is some problem at her end, maybe. Dr. Sadia, are you there?
Hello?
Yes.
Yes, I'm sorry, I couldn't hear. We will provide you with certain medication. It will be in the form of the painkillers, and we will also involve the pain management team in your case. And if these medication don't work, then we have specialized medication which can be given in your bladder. Am I clear so far?
Yes, doctor, you are clear.
Yeah, and if these medication don't work, then the team of the doctors, they can decide for you the surgery as well. Am I clear so far?
Yes, doctor.
Do you have any questions?
No, doctor. Thank you so much.
So I will provide you with written information, connect you to support group, and fix another appointment with my consultant. And right now we will start with the simple measures and painkillers. And we will do the food diary and this bladder diary, and we will check you for waterworks infection.
Okay, all right, doctor.
Okay. Thank you very much for it.
Okay, thank you, Dr. Sadia. Actually, there was a lot of disturbance. I don't know, you exceeded the time. Okay, one thing very important, Dr. Sadia,
Yes,
you missed, yani you took the history for about 8 minutes.
Oh my God.
You know, this is something very dangerous.
Yes, yes.
You are a candidate for MRCOG, right?
Yeah.
Yeah, so you have to learn how to time yourself. You know, I was just looking at the clock. It was just 2 minutes remaining. You are still asking me questions about the history. So please practice. You have a study buddy?
Yes, sometime, not always.
Okay, no problem. You can, you know, just practice with yourself. Stand in front of mirror, just think about the station, be your own role player and try to time yourself. I would really like to appreciate Dr. Monicum. She's every day, you know, attempting the task we are posting in the group, and she is doing the role player thing by herself. So you learn how to time and, you know, finish within maximum 4 minutes. Then you don't have any time for the management plan. Okay.
Yeah.
Although I think with the history, within first 2-3 minutes, it was very clear what is the problem with the patient, right or wrong?
Yeah.
Okay. So you knew, yeah, you knew the diagnosis from the very start almost, and you were following everything very nicely, but still you could not, you know, manage how to finish the station on time.
Yeah.
Okay, so just try to time yourself, you know, everything. This was bladder pain syndrome. And this is again a common station which is coming again and again in the MRCOG part 3 exam. Zaid, anything you would like to add? Then we will go through the bladder pain syndrome.
No, Dr. Uzma, that's enough. But I would like to comment on Sadia as well, that you have rightly mentioned that, you know, she has to take history in at least 5 to 6 minutes, because 10 minutes, you know, the time is so less. If anybody will take, you know, the long in history, then management will be left. Then I'm afraid that, you know, the station is not going to be done. And of course, you know, then, you know, any candidate will be in danger. So all of you guys, please practice in a way that you guys take history in like 4 to 5 minutes. Don't take unnecessary, you know, the history. Like if you think that you are taking too long, so just, you know, stick to your, you know, the basic history template for that station. So, I mean, doesn't necessarily mean that you have to finish your complete template in every station. Okay. So because you have to, you know, talk about the diagnosis, then you have to talk about the management as well. Then of course you have to close the loop. And if you don't close the loop by asking that, you know, do you have any question? Plus I will give you patient information leaflet, and then you can book the next appointment with the consultant. Then your station is not going to be complete. and it is not going to be, the termed as a good station as well. Okay. So all of you, please practice even with yourself. If this is a very common situation that study buddy is hard to find, or because one or other reasons we cannot study with anyone, so don't be upset. Study with yourself. Record your station in 10 minutes time. Try to record it like 10 to 12 maximum, okay, initially. And then listen to yourself. Be your own critic. Be your own teacher. If you cannot do that, either you can take any of your study buddy, any of your family member, ask him or her to be your role player, and then record and then listen to yourself. I remember when I was in my exam, I used to practice with myself. I used to stand in front of mirror and I used to talk to myself. And later I used to think how pathetic I am whenever I used to listen to myself. So it happens. These are all normal feelings. Yeah. Sometimes, sometimes I used to think of myself, oh my God, how pathetic I am. And, this is not how it should be in real exam. So of course you will be, the kind of fluent, you will be good with the passage of time, but not in the beginning. So give yourself time, be easy on yourself. Don't be, so harsh on yourself. The things takes time to, come in the flow. So just, just practice. And I really want to commend for Manikam as well, for her perseverance, for her presence, for her, the hard work. And this is all, every candidate needs to do. And
Thank you, ma'am.
if you are going to, we really, me, Dr. Uzma and other mentors, we always talk about you as well, that, this is how a candidate should be. The full time, the focus, full time, the perseverance, for showing the full time perseverance that, yes, I want to do, yes, I want to present, yes, I want to do. So this is how you learn. Because this part 3 exam is like, and even these days, almost every exam in which the OSCE is there. So it all needs practice. Nobody is going to be a master, by just observing, by collecting the data, by collecting the videos, by just, the listening to the sessions. No, it's not going to help until and unless you are presenting, until and unless you are being corrected. So this is the key to success for this exam. Okay, guys? So this is going to be from my side. Yeah. Thank you.
Yeah, thank you so much, Dr. Zaid. I saw our great mentor, Dr. Hassan here, where he disappeared. I think again he's busy in taking an exam, and then he said he will join. Then I think got busy again. He joined for a while. Anyway, so this is very, very important what Dr. Zaid told you, that if you can listen to people performance station, you can get the notes from, there's so many free things available on Telegram everywhere. But the most important is how you perform it, and how once you perform in front of someone who has already passed the exam, they can correct you. And then you will, work on your weaknesses, and we will help you to work on your strengths. And this is how you are able to pass the exam. Okay, so let's go to this bladder pain syndrome. Anybody want to ask anything?
Yes, Dr. Uzma, Assalamu alaikum.
Walaikum assalam.
I want to ask that, like in this station, the diagnosis is evident from where you start.
Yeah.
Like in this case, we skip some of questions of history in between to short the time.
It's not. As Zaid said, that you should not. It is not mandatory to follow, like Bible, everything which is there in the history template. But if you are already having a diagnosis, then you can quickly just touch, because it is still a pain in the lower abdomen. So you need to touch the other things, like with very short questions. Any relation of the pain with the periods, any relation of pain with your bowel habits, any nausea, vomiting, vaginal discharge, so that STI, IBS, endometriosis, adenomyosis, this is all cleared. And then you are clear that this is diagnosis bladder pain syndrome. Okay. So whatever differential comes in your mind with the chronic pelvic pain, try to ask all those questions, because you have marks for those questions. Okay.
Okay. Thank you.
All welcome. Any other question? No question, I think. All right. So let's go here. Somebody has something. No, diagnosis will not be given, my dear. Very rarely the diagnosis is given. Very, very rarely. If diagnosis is given, then please don't ask any history. You start from the diagnosis. Yeah, Dr. Athiya, it is, if the, that's what I'm saying. Normally, if it's a communication with the patient or a history taking they expect from you, then you don't need to ask anything from the history. You already have a diagnosis, then you will say, okay, the patient is already aware of the diagnosis. Then you will say, are you aware of your diagnosis? Do you know what you have? Okay, so did you read about it? What do you know about it? And then on that, you start that, okay, this is your diagnosis and this is how we are going to manage your case. What was your case, Dr. Athiya? Can you just open your mic and let us know? Dr. Athiya? I don't know if she's here or she's... just click unmute and you will open the mic.
Yes, I'm sorry, I forgot.
It's okay, no problem. Yes, doctor.
It was given in the question. It was the person was here to meet the consultant, and she had the diagnosis of bladder pain syndrome, and we need to clear her concerns. So what we but the domains were checked as information gathering, communication with patient, communication with colleagues, and patient safety. So what ask in the history?
Okay, so this patient already diagnosis was there and patient was aware of the diagnosis?
Yes.
So your diagnosis was what, doctor? Sorry, I didn't get what?
She was here to discuss the diagnosis with the consultant, and the consultant was aware as in this case, but in that scenario, there was the diagnosis of bladder pain syndrome and she was aware of it.
Okay, so in that case, you can just ask her a brief history of her food intake. Her, like this patient was a smoker, so this is a triggering factor. Then her spicy food is a triggering factor. So this type of history, if it is not provided to you, then you have to gather this history. That means they want to know if you know that what triggers the bladder pain and what she needs to avoid, how to go for a healthy lifestyle. And then you have to cover all that, you know, this 1, 2, 3 for all the medicines which you will start from first line, second line, third line, like that. So you need to cover all that.
Okay. Thank you.
Okay. Welcome. Okay, before we go on to bladder pain syndrome, Dr. Pushpi is here. Dr. Pushpi, are you there?
Hi, Dr. Uzma. How are you?
Hello, thank you so much, doctor. I'm fine. Thank you so much for joining in. I just wanted, it is my honor to have Dr. Pushpi here. She's not only my colleague, but she is a gold medalist in the recent Mrcog exam. And mashallah, she got 89% marks. So I requested her to join our session and, you know, give us some tips and tricks how to pass this exam. She passed in the first go with a very excellent performance. And very well done, Dr. Pushpi. We are so proud to be associated with you and working with you. Thanks for joining in.
Hi, yeah, thank you so much, Dr. Uzma, for your kind words. I'm so much pleased. And as, yes, like, let me know everybody that it's Dr. Uzma, like, who is like my mentor, and she's like more than my friend. She always encouraged me, and she told me, like, you know, I can do it. So, like, you know, it's like everything starts from home. So for me, everything started in the hospital with my very own colleague, Dr. Uzma. So I should be thankful to have such a colleague with me. So there are only few tips. You have got a very good mentor, so she will guide you through. there are only few things which, like, when we start this journey, we have to keep it in mind. So first is most important is like be very organized and systematic. So there are only few modules. So just make sure that you are starting with one of the easiest module. Like, maybe like for me, I found that early pregnancy was a bit easy compared to other things. And then I stepped up to the ladder because, like, if you start with a very difficult module, then in the beginning only you will not be having any mood to read or do anything. So in early pregnancy, there were not many things, so I could do it. And yes, so be organized and systematic means like we need to organize our thoughts. There are so many things to read. So first is like always the Bible is the GTG and nice. So without that, yes, any MRCOG journey is like very incomplete. So you should have a thorough idea, because what your mind knows, your eyes see. So same way what your mind knows, your mouth speaks. So unless you are good in little bit about theory, difficult to really go for the applied knowledge. Then second thing is coming to the communication, because part 3 is unlike part 2, is mainly the communication part. So just don't take it like it's going to be a interview or you're doing a viva or something like that. Just think yourself as a doctor and you're treating your patient. And or maybe you can take yourself as a patient, like, as a patient, what you exactly want to know. You don't want to know loads of theory, you want some empathy, you want some sympathy. So make sure that the conversation goes in a the communication should be like very flowy, and it should be like very easy. So that is what they say, don't use the medical term, use the layman terminology. So that is very important. So that will come only with the communication, because yes, we are not from English speaking country. Generally we communicate with our patient with the very own language, whichever we are comfortable with. So that is the part. So you can do that either by practicing with your partner, but unfortunately everybody is not blessed with the partner. So you can do it with your own recordings. That is what I was doing. Sometime I was, because my work schedule is like very hectic. So sometime I was lucky enough to get Dr. Uzma, but she herself is busy one. So I used to record my own recording, and then, you are the best critic for yourself. So you can know, like, where you're lacking and what exactly you need to do it. Then third thing will be like, yes, books are important, because they are the books recommended by the college, like Lisa's Joel, even though it is an old book, and then some new books like Justin Conji, Oxford. So I feel that it's important that instead of running around and seeing some incomplete scenarios and all, try to go through the books, because once you start the practicing going through the books, then it will be very easy for you to streamline your preparation. Like, like exactly where to concentrate, which points are you missing. Like maybe Lisa Joel will not give you exactly, no, this is the answer and you have to. It will say the competent candidate will do like that. So once you record and you see that all these points you have included, you get an idea about it. Okay, so these are the main important tips. Rest is like, yes, practicing and persistence is very important, which will give you a lot of confidence for the exam. And that's it. I always say to everyone, nothing is impossible. If I can, everybody can. Thank you.
Thank you so much, Dr. Pushpi. Really, these things are very, very important, that you have to continue your hard work. Don't get tired, even if you have attempted and not made it. It's okay, it doesn't matter. It is just a matter of time. Every attempt, it increases your knowledge. And try to be focused, try to perform. Most important thing is to perform. If you don't have a partner, perform in front of the mirror, record yourself, listen to yourself. I think we all have done it. Me, Zaid, Dr. Pushpi. If you cannot have a partner all the time, because most of the people are working, so your time cannot match with some other person all the time. So you have to perform and listen to your own performance, and then understand what is your lacking. Then you can work on it. Okay, thank you so very much, Dr. Pushpi. I'm really very, very proud that you are a gold medalist, mashallah, mashallah. She passed European board also with me in first attempt, and she is a very, very intelligent girl, mashallah.
Thank you so much, Dr. Uzma. Like, I'm always pleased to work with you, and like, being appreciated by you is like beyond my imagination. Anyways, thank you so much. Anytime,
It's
my
it's
pleasure. My
really
pleasure.
big thing to get a gold medal from RCOG and not, practicing in UK, practicing outside, like we are here in UAE. So it's a very big thing, and it should be appreciated. I feel like that.
Yeah, thank you so much. And good luck, everyone. You can do it with Dr. Uzma. I'm very sure.
Thank you so much, Dr. Pushpi. Okay, so coming back to the bladder pain, anybody want to ask anything from Dr. Pushpi, please? Before she leaves, she has a duty to go. Okay, all right. So thank you, Dr. Pushpi. I know you have to go for the duty. Good luck and have a quiet duty, inshallah. Okay, so we'll come back to the bladder pain syndrome. So as we were discussing, that the diagnosis of bladder pain was very clear from the very few questions from the beginning. So then what you need to know, as you have to follow the template of the chronic pelvic pain and try to take all the differential diagnosis. Somebody is saying something, sorry. Please mute yourself. Oh, somebody's mic is on, kindly mute, please. Okay, all right. So you start with your history and how the things are affecting the quality of life. This is all from your guideline, okay? So it is there. Just if you know how to, if you covered this chart only, you will pass the station. So once you are coming close to the exam, initially you have time and you can make your own notes, what to ask in the history, what will be your differential diagnosis, what will be your treatment plan, management plan. So make small flashcards for yourself, because in the remaining few days before exam, you don't have time to go through all the big GTGs and SIPs and all. So you still have time to go through your flashcards. And since they are made by you, so it is easy to gather information and follow what is the treatment plan especially. So Dr. Sadia unfortunately could not reach till here because of long history taking. So these are the things you need to ask from the history. Then investigation, I don't think you ask anything in investigation, doctor, because there was a shortage of time. And this is the investigation which you need to do. If there is urinary tract infection, you need to treat the cause. Sorry? Somebody's mic, please. Whose mic is on? I don't know, maybe she doesn't know her mic is on. Okay, all right. So the first line of treatment is conservative management, which includes simple analgesia, stress relief, dietary modification, try to do some exercise, physical therapy, support groups. And if this treatment, this conservative first line treatment fails, then you refer the patient for the secondary care. Secondary care is oral amitriptyline or is off-label use for this condition. And if this treatment fails, then you have a MDT, pain team, and a clinical psychologist. Third line treatment, they expect you to know, if like Dr. Athiya said, the bladder pain syndrome was already, the diagnosis was given already, then you just have to ask what communication from the patient will include her history, her habits, which you need to address that, okay, this food you need to avoid, this is smoking you have to stop and go for a healthy lifestyle, exercise. These the things which are not in the scenario, you have to ask these from the patient and then come to all these treatment, because then they expect you to tell all the first line, second line, third line, fourth line, fifth line, everything they expect you to tell to the patient. Okay. So number one is the bladder diary. You have to keep the frequency volume chart, a food diary, check the urine for any infection, and for the urea plasma chlamydia. And then those with the suspicion of malignancy, so you can have a urine cytology also. A cystoscopy and referral to urology if it is required. Then this is the example of the bladder diary. It is all there in the guideline. Then your differential diagnosis, of course, as I told, in chronic pelvic pain, whatever differential like endometriosis, adenomyosis, STIs, PIDs, whatever comes in your mind, please exclude that in your history taking because you have marks for all these. And when you will refer, we already discussed, this is all from this chart, and then support group and how you will follow this patient. How frequently you will follow, and then when you will refer her for the secondary care and urogyne clinic. And these are the advanced investigations that might be required in this patient, but normally you don't reach up to there in the 10 minutes time. So this is all, guys. Anybody want to ask anything? Hello, there are 31 people. Nobody want to ask anything?
Hello, Dr. Uzma.
Hello, yes, doctor.
I'm Dr. Bismil. I would like to say, ask that if because of a time, if we are unable to complete the loop, like if we don't offer PIL or another appointment with the consultant, because in the face-to-face format in the UK, we won't be able to see the time. So in that case, what means how the station will be marked?
You see, there are two ways to do it. One is, as Dr. Muhammad, all of us know Dr. Muhammad, and we all are very, very thankful to him because he is the only one who used to conduct so many sessions free of cost. He used to make all the templates, and it's all available in his group. He always says that you can do it right in the start of the station, that okay, I would like to ask you a few questions about your complaint, and we will come to a mutually agreed management plan. I would like to arrange another appointment with my consultant, offer you some patient information leaflet, and I might need to examine you in the presence of chaperone with your consent. So this is hardly 30 seconds, but it covers everything. Okay, so either you do it this way, or you can complete your history template, and then at the end of the station you can say, okay, I have some support groups we have and some patient information leaflet. You can go home, read about it, and I'll arrange another appointment with my consultant for further plan of management. So both ways are okay. I feel if you are thinking that you might miss this thing all, so you complete it from the beginning. In first 30 seconds, you make your agenda. This is my agenda.
Okay, thank you, Dr. Uzma.
Welcome so much. Okay. Yes, Zeb? Yeah, bladder pain for the pregnancy. I will just tell you what are the options for pregnancy. Wait, I'm going other way around. Okay, so Dr. Zaid, as you pointed out for heparin injection and during pregnancy, actually heparin injection can be given during pregnancy, but you need to discuss in advance what you will give during pregnancy if the patient is conceived with the bladder pain syndrome. So or even oral amitriptyline and intravesical both are safe, they can be given. But as I said, you need to have a MDT approach in patients who have any other medical problems beside pregnancy, and then go with the combined treatment plan. Okay? Only this DMSO you cannot give. Any other questions, guys? Okay, so I don't think we have any more questions. So I hope you found this session beneficial for you, and we will have plenty more sessions. So please join in and try to get benefit as much as possible from these sessions, because even whatever you will retain in your mind, at least something will be there, you know. So in the exam, if something comes, you will remember that, okay, this one we talked about, and you can perform better in the exam. Even if by listening, sometimes it helps really. So please, thank you so much everyone for joining in, and any questions I'm here to answer. In our free group also, try to participate as much as possible. It helps. The more you perform, your confidence boosts.
Exactly. So I want to tell and supplement again the same thing, that please do get benefited, because we are running a free Telegram group with the name of Part 3 Guide, where we all are there, and you know, we all are MRCOG, and of course, you know, some of us are examiners as well. So yes, I mean, we are in better position to guide you guys. Okay, so do try to take as much as help as possible. Do try to be active, and from my side, I would just like to give you only one advice: practice, practice, and practice. Okay, don't just be, you know, the silent dummies, because this is not the exam in which you just need to be silent. Okay, you have to speak, and you have to be corrected, because of course, you know, until and unless, you know, somebody tells us that, okay, this is good, this is bad, so we are not going to be in good position to go for this exam. Okay, and on the other hand, we have to practice in a way that, you know, we just finish our station in 10 minutes time. Okay, and this will only come by practice, because in our real life, of course, we do see our patients in our day-to-day practice, but of course we don't, you know, they watch out for time all the time. Okay, so we can give 15 minutes, we can give 20 minutes, but in this real exam, because we have to finish our station in 10 minutes time, so yes, that needs a lot of practice, that needs a lot of, you know, the rehearsal. So guys, you know, stay active, you know, the keep practicing, and this is the only way by which you can have a good practice and good grip on this MRCOG Part 3. Okay, and likewise, the same advice for FCPS and MCPS candidates as well, because I believe they are going to have the same rehearsal, they are going to have the same exam this time. Okay, so all the best, very guys, all the best, all of you. Keep practicing. Okay, keep growing, stay focused, and that's it.
Thank you so much, Zeb, for being here. And I know you are a very busy person, but thank you so much for sparing your time. And
No. For you, anything. For you, anytime.
Thank you very
You
much.
know
I'm
that.
really obliged. And very important, Dr. Zeb pointed out that you have limited time for the exam. So the key to success is practice. The more you practice, the more you are confident, and you can easily pass the exam. But you know, keeping quiet and just listening to others won't help. Believe you me, it won't help. You have to perform. You have to, you know, get some feedback. Even if you feel you cannot get feedback, but at least perform yourself and listen to yourself. That is going to help you. Okay?
Exactly.
All right. Thank you so much, everyone. And thank you, Zeb, again. And thank you, MedExam team.
Welcome,
So
Dr. Uzma.
we
Always
will
there.
meet again, inshallah, with some other good topic and with active participation from all of you. Thank you very, very much, and bye-bye.